So, hello. Welcome to your virtual simulation. My name's Meg. I'm one of the clinical skills tutors, and I'm going to be doing a simulation remotely today. Okay. This is Selena. She's going to be my hands. So while we do the simulation, if you want anything doing, if you ask Selena, and then I will give you the results. Okay. So, just before we start, can you just give us a wave and introduce yourself? Tell me what year you're in and what block you're on, please. So,
after you, Ray.
Okay, I'm year 3 medicine block right now.
I'm Ellie and I'm year 3 on surgical block.
Lovely. Okay. So, what we're going to do, I'm going to give you, I'll assign you roles. Okay. So, Ellie, did you say you're on surgical?
Yeah.
Yeah. Okay. So, I'm going to ask you to do the A to E if that's okay, because this is a medical simulation, so it'll hopefully get you thinking a little bit about when you go there. So I'll give you the A to E to do, please. And Ray, if you could please interpret any investigations that Ellie asks for, and also if you could just think about any feedback as well that you'd like to give her at the end of the simulation. Is that all right?
Yep.
Everyone happy with how to use Teams and what's going to happen?
Mm-hmm.
Yeah. Okay. So Ellie, I'm going to give you a handover, and then I'd like you to go review the patient, please. So this is Barry Strange. Okay. He was admitted to CDU. Okay, with shortness of breath and difficulty in breathing. Okay. He's never had a CDU admission before, and he has a past medical history of hypertension and COPD.
Okay.
The doctor came and assessed him. He's only just come in. The doctor came and assessed him and did an ABG, but unfortunately he had to be called away to an emergency.
Okay.
So I'm a bit worried that he's deteriorating. Can you please come and have a look at him for me?
Yep. Okay.
Yeah. Are you all right to repeat that back to me so I know that you understand what?
Yep. So this is Barry. He's been admitted to CDU with shortness of breath, and he's never been admitted before, and he's got a past medical history of hypertension and COPD. We're a bit concerned that he's getting worse.
Lovely. Okay. So can you go and see the patient for me, please, Ellie?
Yep, of course. Okay. So hello, Barry. I'm Ellie. I'm a medical student. What's your date of birth, Barry?
Okay, and he tells you that his date of birth is the 21st of July, 1931.
Okay, and can you just confirm your name and surname, Barry?
Yeah, it's Barry Strange.
Okay, nice to meet you, Barry. How are you feeling?
Oh, I'm all right. I just can't catch my breath.
Okay. Has this been happening for long, or has it just come on now?
Oh, a couple of hours now. I thought I'd be all right at home, but the wife said I better go in.
Okay. All right. So Barry is talking to me, so I know his airway's patent, but he sounds a bit breathless. So I'm gonna just move on to B. So can I have his oxygen sats?
Yes. So Sal puts his oxygen saturations on, and they are 87% on room air.
Okay. So with a background of COPD, we'd aim for 88 to 92. So he's just a little bit low. But we'll give him some oxygen just to get those up a bit. So perhaps not too much. So we'll perhaps go for a Venturi mask.
Okay.
Start with and just titrate.
What percentage would you like, Ellie?
We'll go for just 2 litres to start with.
Okay. Selena will do that for you. So that's on now.
Okay. And do we have his rest rate as well?
Yeah. So it comes back. The rest rate is 27.
Okay. Right. So that's quite fast. Okay. Right. And can we check his sats again now he's on the oxygen?
Yeah. You put the saturation probes on, and the sats are now 90.
Okay. So that's about right. So we'll leave him with that at the moment. So now I'm just going to examine his chest. So I'll start by testing expansion.
Yeah. So when you do your chest expansion, it is equal.
Okay, that's good. And then we'll just percuss over all the like upper, middle, and lower zones.
Okay. So resonant, 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 resonant.
Okay, great. And then we'll listen with the stethoscope over the same 6 areas.
Yeah. So before you even put the stethoscope on, Ellie, when Sal gets close, she can hear an audible wheeze.
Okay.
And then when she puts the stethoscope on, you can hear wheeze, 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 wheeze.
Okay. All right. Well, so that sign is airways might be a bit small, so we might consider at this point giving him perhaps a nebulizer.
Okay. What would you like to give?
So I think we'll start with just some salbutamol.
Yeah. How much?
5 milligrams, I think. That has completed B, so we'll move on to C now.
Yeah.
So can we just check his fingertips and see what his capillary refill?
Okay, so that comes back at 2 seconds.
Brilliant. Okay. So then just if we can feel his pulse, radial pulse.
So you can feel the radial pulse.
Okay. And what's the heart rate?
So the heart rate is 115 beats per minute.
Okay, so that's quite fast. Okay. All right. And then can we also check the blood pressure?
Yeah. So Sal puts your blood pressure cuff. She very good. Puts your blood pressure cuff on for you, and your blood pressure comes back at 120/60.
Okay. So the diastolic's a little bit low, but I think it's still above. Well, it's above or equal to 90/60. So I think he'll be okay for now. But we'll pop some cannulas in case he does deteriorate. So if we could have 2 wide bore cannulas in, so 1 in each arm.
Yeah, I think he's already got 1.
Okay.
Would you like another one?
Yes, please.
Okay.
Okay.
Yeah.
Fine. Okay, and then moving on to his chest, we'll just have a listen to his heart.
1 minute.
That's okay.
Second cannula.
Thank you.
No problem.
Okay, thank you.
Okay. So heart sounds are normal, no added sounds.
Great. Okay, thank you. Okay, and then if we could just listen as well, have a listen at the lung bases on the back, check for any kind of pulmonary edema as well.
Yeah. So Sal listens at the back, and you can just hear a wheeze. You can't hear
Okay, so still
anything else, really. Yeah, it's the same.
Good. Okay, good. Fine. Okay, so then that completes C, so we'll move on to D. So if we could just, is he still conscious and talking to us?
He is, yes, he's alert.
Okay, so that's good, he's alert. And then can we just check his blood glucose with a finger prick test?
So Sal takes the blood glucose, and that comes back at 5.7.
Okay, brilliant. That's fine. And are his pupils equal and reactive to light?
Reacting, and they're equal as well.
Great. Okay. And what's his temperature?
And it's 37.2.
Great. Okay, that's good. Okay, fine. So now move on to everything else. So we'll just have to fully expose Barry. And as he's awake, we'll ask for his as well first.
Yeah.
And just check his legs, we'll check his feet, we'll check his whole body for anything, any scars, any signs of any infection, anything like that.
Okay. So there's no signs of infection, no swelling, no scars.
Okay.
Everything looks fine.
Right, so then I suppose we need to think about ordering some investigations. So perhaps should have done that as I went through. But if we just go back to the A, B, C, D, E again. So with the breathing, I think we'll like to order a chest X-ray.
Okay. Do you want me to get a nurse to take him down?
Yes, please.
Okay. We'll organise that for you.
Okay. And he's saturating well, so and don't really suspect PE or anything like that at the moment. So and then we'll move on to well, and other things. Sorry, we started him on oxygen, so we'll do an ABG.
Okay. So Ellie, I've got the ABG here for sorry, for Barry that they did before. Can you see that?
Yep.
Yeah. Okay, so we did the ABG. This is the one that the doctor did on air before we put him on any oxygen. Okay, so
Okay.
Ray, would you please be able to interpret this in ABG for me, please?
Yeah, pH is low, so this patient's acidotic, and carbon dioxide partial pressure is high, so most likely a respiratory acidosis here. And it possibly because it's both hypercapnic and hypoxemic patients in respiratory failure, type 2 respiratory failure. Yeah.
Yeah. Okay. Anything else of note on any of these results?
In terms of what's out of range, not am I seeing anything? The only thing I'm seeing right now is the SATs are low, and oh yeah, lactate is lactate is high, glucose is high. So I'm wondering if do we have ketones anywhere? We don't have ketones.
We don't. No. So the lactate specifically. Why do you think that might be high?
Because the patient is having respiratory failure, so it's patient's going through anaerobic respiration. So there's more lactate being produced.
I've done a portable chest X-ray. Okay. Ray, if you would be able to interpret this X-ray for me,
Oh my
please.
goodness.
Can you see it all right?
Yeah, but not the full thing. I'm getting part
Okay.
of the diaphragm only. Is there any way for you to? Yeah, that's good.
Is that better?
Yeah, a lot better. Okay. So I'm gonna guess because it doesn't state that this is a PA chest X-ray. It doesn't look rotated. Based on actually looks slightly rotated, I guess, based on the distance of the clavicle to the spinous process. But it looks like it's well penetrated. I can see all the contours in the right and left heart borders fine. I can also see the diaphragms on both sides with the claustrophrenic angles. I'm not really in terms of the lungs. It looks like it's well inspired. I don't know if I'm seeing any obvious signs, but it does look very hyperinflated with the hemidiaphragms pushed downwards, which is in line with the COPD, I guess. Not seeing any signs of menisci or any pleural effusion whatsoever. Yeah, I don't know if I'm seeing even any consolidation, to be honest, which I thought I would find.
Okay. So if you were to determine this X-ray, would you say it was clear?
Yeah, I would say it's clear, but with hyperinflation.
Okay. All right. Thank you.
It doesn't seem like there's an infection. He hasn't got a temperature, and the chest X-ray is clear. So I think it sounds quite like a acute exacerbation of COPD. So just keep him on the nebulizer for now, and hopefully he will be respond to the treatment.
Yeah. Is there any other treatment that you've diagnosed acute COPD exacerbation. Is there any other treatment that you're aware of, or how to do that? Or do you know where you may find that information out?
I would. There's probably an algorithm which would be very useful.
Okay.
For
yeah. Let me share. You see that?
It's coming up. Yep, see it now.
So this algorithm, excuse me, is actually used in the emergency department, but because it's CDU, it's very similar, but also just to make you both aware, like every ward has their own algorithm. Where do you want to send this patient?
So he's in CDU at the moment, isn't he? So I think he'll need to go to a ward. I don't think he'll qualify for ITU or anything at this stage. He's responding well to treatment, so I think certainly go onto a ward as he's requiring oxygen still and a nebulizer. Yeah.
Okay. So I'll stop you there because you've done everything that you needed to do.
Thank you.
Okay. So I'll give you both a little bit of feedback. Ray, could you give some feedback to start with, please, and then I'll jump in.
Wow, just generally, I was like really impressed because I was like, there's no way I could have said whatever you said like that, Ellie. Honestly, that was amazing. You sounded like a pro. Yeah, and you were very systematic, very structured with your ABCD, and it was very natural. It doesn't feel rehearsed or at all. So,
thank you.
I don't know about any negatives. I don't think I have any. So that's awesome.
Ellie, I'll start with you. How did you find it?
Yeah, I think it was okay. I think I should have done the investigations as I'd gone through the first time. I think I kind of forgot about those completely. But I think going through again was probably the best way to handle that mistake, like going through the ABCD again.
Yeah.
And I learned not to give the salbutamol with oxygen.
Good. So you learned something. That's good.
Yeah, definitely.
Yeah. Okay. So I'll just go through your A to E because then it'll be easier for you. I've got no more feedback for you. It was so good. Please keep doing what you're doing because it's obviously working. Like really, really good.